All right, without further ado, I'd like to welcome Dr. Isabel Neuringer, who is a pulmonologist who works in post-transplant work as well. And I will let Isabel continue with giving you a little bit of her background.
Thank you so much, Laurel, for your kind introduction. I'm going to share the slides right now. Are we able to view?
I don't see the slides yet.
Okay. Apologize. I'm sorry. I apologize. Try to get through everything. I apologize for the delay. We'll try again. Share screen. Okay.
Yep, I see the slides.
Sorry about that. Apologies for the delay. So in 2022, the CFF clinical trials team partnered with the Digest and CF lung transplant consortia teams to host a 5-part virtual workshop on GI-related aspiration and advanced lung disease and the transplant population, as well as people with CF. This effort is based on the recognition that reflux, and in particular aspiration into the lower airways, exacerbates pulmonary disease and lung transplant rejection. Appropriate diagnosis is very complex and poorly understood. This group is composed of a multidisciplinary team of gastroenterologists, CF and lung transplant pulmonologists, thoracic surgeons, nurse practitioners, community members, and CFF staff. This slide highlights the breakdown of the different workshops, starting with our attempt to define GRASP, diagnostic techniques, medical and surgical options for therapy, a review of case studies, opportunities for partnership and identification of gaps in knowledge and key questions. I'd like to start with an overview of GRASP, or GI-related aspiration, why this is problematic for patients with CF, advanced lung disease, and lung transplant, and then ultimately review gaps in our knowledge. This slide shows a diagram of retrograde reflux coming up from the stomach and heading towards the lungs. Some reflux, as we understand, is physiologically normal, but can cause respiratory illnesses. Problematic reflux describes illnesses of the esophagus, stomach, and/or both the esophagus and stomach. And this results in esophageal dysmotility, gastroesophageal reflux disease, and gastroparesis. Reflux is associated with direct and indirect effects on the respiratory system. And this is what we're hoping to further define and understand, or the concept of GRASP. As mentioned, reflux can directly affect the lungs, causing pneumonia and direct aspiration. It can also exacerbate conditions underlying lung disorders, such as CF, non-CF bronchiectasis, interstitial lung disease, COPD, chronic cough, and asthma. There are physiologic checks along the way from the stomach up to the lungs to try and reduce reflux. We have the lower esophageal sphincter, the upper esophageal sphincter, and the glottis. So how do we define GI-related aspiration? Well, this continues to be a work in progress, even after our 5 workshops. But we hope to move forward with future discussions and investigations. As we know, this includes problematic acid and non-acid reflux and/or dysmotility of the esophagus, stomach, or both the esophagus and stomach, causing direct and indirect effects upon the respiratory system. This may result in respiratory symptoms, including cough, wheeze, shortness of breath, lower airways inflammation and/or infection, airway obstruction, and/or pneumonia. This slide highlights the impact of GRASP in the lungs. Overall, GRASP augments inflammation and amplifies infection in the lungs. In both CF and transplant, some of these processes ultimately weigh in on the pathophysiologic state of the lungs. We have polymicrobial infections, we have inflammation with cytokines, and a prominent inflammatory marker called neutrophil elastase, the role of antibiotics which alter the lung physiology, comorbidities such as bile aspiration, which plays a significant role in GRASP. And in CF particularly, we have the impact of GRASP on biofilm formation, as well as the impact of CFTR modulators. We are focusing upon GRASP since this is problematic in people with CF, advanced lung disease, and post-lung transplant. This slide will show the mechanical and physiologic factors which can worsen GRASP. So starting in the stomach, we may have an increase in intra-abdominal pressure, a low gastric pH, and gastroparesis. Heading up towards the esophagus, we may run into increased dysmotility in patients with CF, problems with the lower esophageal sphincter, and ongoing dysmotility all the way up to the top of the upper esophageal sphincter as well. Progressing through the pharynx to the glottis, there also may be vocal cord dysfunction from recurrent episodes of regurgitation and reflux. This ultimately heads down into the airways. In patients with an underlying lung disorder such as CF, there's a mechanical disadvantage in terms of the lungs being hyperinflated with increased work of breathing. This process from start to finish therefore results in aspiration, can result in aspiration into the lungs, causing ongoing inflammation, remodeling, and recurrent cycles of infection. So what is the impact of GRASP starting with CF? There is a high prevalence of acid exposure in CF, including silent reflux, and testing is not uniformly standardized. The majority of CF patients are on proton pump inhibitor therapy, PPIs. They have reflux symptoms weekly, and a third reported worsening respiratory symptoms due to reflux. We understand that GRASP in CF may contribute to worse clinical outcomes. Several studies have associated GRASP in CF with increased cough, a lower FEV1, and a decline in breathing tests, as well as pseudomonal infections. As mentioned, GRASP in CF may contribute to a worse clinical outcome, and the finding in sputum of increased bile acids, neutrophil elastase, again, a prominent marker of inflammation, and an association with a decline in FEV1. In this particular study, one can see the panel in the lower left, 4 groups of patients were compared, those with cystic fibrosis, healthy patients, chronic cough, and asthma. 56% of patients with CF had elevated bile acids in their sputum compared to healthy controls, chronic cough, and asthma. Elevated bile acids were associated with increasing neutrophil elastase and also a decline in FEV1 or PFTs. What is known about GRASP post-lung transplant? Well, post-lung transplant, there are alterations in chest wall mechanics and physiology, also the impact of immunosuppressants after lung transplant. All these factors may include vagal nerve injury, associated loss of cough reflex, impaired mucociliary clearance, and overall calcineurin inhibitors and anti-rejection medicines can slow blood flow to the gut. So we have slowed gastric motility. This can also increase symptoms of nausea and subductive reflux. Many studies has also shown the incidence of acid exposure increasing from pre-transplant to post-transplant. After lung transplant, increased acid exposure has also been found to be associated with chronic lung allograft dysfunction, also known as CLAD, an overarching, all-encompassing diagnosis of lung dysfunction, of which bronchiolitis syndrome, BOS, is one form. Graft post-lung transplant is associated with increased markers of inflammation, as we can see on the right, and there are many markers of inflammation that are followed after transplant. Increased bile acids with taurocolic acid here, and these result in activating the immune system as well as many other arms of the immune system to result in acute rejection or chronic lung allograft dysfunction. In this recent study by Urso and colleagues, they found that bile acid aspiration after lung transplant is associated with earlier clad development and reduced survival. These two lines, this line shows a lower level of bile acids and the red line a higher level of bile acids. As you can see, those who have lower levels of bile acids in the lungs have better freedom from chronic lung allograft dysfunction. Similarly, on the right, those who had lower levels of bile acids also had a higher improved survival. There also was an increased rate of infections in those patients who had higher levels of bile acids in the lungs. This slide shows that post-transplant anti-reflux surgery can reduce the effects of graft inflammation. As one can see, all these graphs show pre and post anti-reflux surgery. All these lines are trending downwards. Thus, the anti-reflux surgery really improved patient survival and clad by reducing these inflammatory markers. So this part of this introduction leads us to gaps in our knowledge and areas for further investigation. One of the first gaps in our knowledge is that aspiration is indeed difficult to diagnose. Findings in the lung are heterogeneous for aspiration. These slides show some of the different histopathological forms of aspiration, ranging from filling of the air spaces, like in a pneumonia, to inflammation just around the airway, bronchiolitis, so airway inflammation, as well as filling in of the air spaces with inflammatory cells. There's no consensus on the pathological diagnosis for aspiration, but does include all these forms. We don't know if about the role of infection, if this is a cofactor or a byproduct. So we are left with diagnosing pulmonary aspiration based on changes in histopathology, imaging such as X-rays and chest CTs, and pulmonary function testing. A second gap in our knowledge is to determine who is aspirating and then proceed to perform testing. What is being tested? Current reflux monitoring techniques are geared at diagnosing abnormal reflux related to the esophagus, but lack specificity for diagnosis of lung aspiration. How do we determine the correlation between reflux episodes and clinical relevance? The table at right shows a degree of confidence for the diagnosis of pathologic reflux, as well as common testing procedures. We still are working to understand how many episodes of reflux correlate with a clinical manifestation. This table highlights the knowledge of the pros and cons of testing. I'll just give you for one example. A barium swallow is done quite frequently in the pre and post-transplant setting. However, cannot specify the amount of reflux nor the type of motility disorder. Similarly, multi-channel intraluminal impedance pH testing may be challenging for a patient to tolerate, especially patients who have advanced lung disease. A third gap in our knowledge relates to the role of PPIs, and this has been an ongoing theme in our discussions throughout the 5 workshops. The majority of CF and lung transplant patients are currently treated with proton pump inhibitors. This slide is from the CFF 2020 patient registry report. Around 50% of patients are treated with a PPI, and then 10 to 15% are treated with an H2 blocker. Standard reflux therapy may be beneficial, as one can see in this review, showing therapeutic gain for healing of esophagitis, heartburn relief, chest pain, and chronic cough. However, there's a body of literature suggesting that there are detrimental effects as well. In this graph at left, this was a study comparing CF patients on esomeprazole, a proton pump inhibitor, versus placebo. And in this study, there was a shorter time to CF exacerbation in the patients on the esomeprazole. A second point is that acid suppression does not decrease reflux events. It reduces acid alone. In this group of patients on proton pump inhibitor therapy, 97% of patients still continue to have reflux episodes, likely non-acid reflux. The data for proton pump inhibitor use after lung transplant is generally more compelling and more positive. There's also a body of literature on this as well. This study shows, by Chan and colleagues under review, early PPI use after lung transplant is associated with less acute and chronic rejection, as one can see with the improved survival curves in patients who have had timely treatment of their GERD for acute rejection, bronchiolitis obliterans syndrome, and chronic lung allograft dysfunction. Similarly, in this published study by Chan and colleagues, PPI use after lung transplant is associated with less acute allograft rejection and improved survival. Lastly, another gap in our knowledge is what is the correct timing of testing for grasp. Pre-transplant testing is routinely performed, but the physiology may change after transplant. Thus, there is another need for testing after transplant. There is no consensus among lung transplant centers about the approach to testing, what tests, and the timing of testing. A recurrent theme throughout this workshop has also been that grasp symptoms and/or symptoms of reflux correlate poorly with findings on testing, and we need to continue to keep this in mind. Overall, we need a better standardization of our testing protocols and procedures and indication for testing. Current testing, which is done pre-transplant, it usually includes barium swallow, gastric emptying, pH probe and impedance, and esophageal manometry. These are important because a risk factor for high or substantial increased risk for poor transplant outcome, according to the ISHLT, International Society for Heart-Lung Transplant consensus, is the presence of severe esophageal dysmotility. We need to focus on defining this better, identifying it better, optimizing it, and treating it in a better fashion. These gaps in our knowledge led us to our last workshop 5, where the group brainstormed about which areas should be prioritized and subsequently voted on the best questions. The categories included biomarkers, surgical interventions, including a routine randomized controlled clinical trial, what medical interventions are available for clinical trials or for therapy as well, understanding patient phenotypes, and lastly, what the top questions are. These questions are ranked by the number of votes, with the top vote getter here at the top. Can we try and standardize testing for grasp? What is the timing for anti-reflux surgery, preemptive or reactive? Are there non-invasive ways to measure grasp? As we know, we currently do a range of GI testing, including upper endoscopy, as well as sputum collection and bronchoscopy in an experimental fashion for the BAL looking at bile acids. Can we define grasp to conduct further studies? Do we need the histopathology? Can we redefine reflux based on what we find on aspiration, working from the other direction? Are there interventions or medications we can give which will make a difference in aspiration markers? And lastly, what is the best assay and methods to assess airway bile acids, which may be one of the putative biomarkers? So this is a very brief introduction about what the current issues, definitions of grasp, where we are with our current gaps in our knowledge. I'd like to thank the participants of the GRASP workshop series, including our co-chairs and planning committee, as well as the CFF staff, which have helped us work through these workshops. slides I've borrowed heavily from my colleagues here in the group. And I'd like to hand the session over to Laurel and Doctors King and Velez.
Thank you so much. All right, we are going to have a quick panel session. And then we will go to Q&A. And again, please, as a reminder, if you have any questions, to put them in the Q&A box. All right, first question for our panel. How did this topic become a focus of research for this workshop?
Thanks, Laurel. I'll take that one. My name's Jeff King. I'm a adult gastroenterologist out of National Jewish in Denver, Colorado. Along with Chris Velez, I was one of the awardees of the CF Foundation's Digest training program, which stands for Developing Innovative Gastroenterology Specialty Training. And this was really an initiative on behalf of the CFF that recognizing that the knowledge in the treatment of CF-related GI conditions was lacking. And in order to identify people who had an interest in this area, they developed this Digest program. And so there were nearly 20 of us, adult and pediatric gastroenterologists around the country. And as it was a 3-year program that just ended last spring for our cohort. And as part of that, the first year, we take part in webinars and conferences given by the leaders of the Digest program. And then the second 2 years, the individual talks are given by the awardees. And one of the talks I gave at the end of last year was about reflux in CF. And really what I highlighted during that talk to the rest of the group was demonstrating that there certainly were a number of reflux studies that have been done in CF. And while it was recognized to be a problem, those studies that had been done were very haphazard, were often based on symptoms rather than actual testing, were very heterogeneous, sometimes using certain methods and other times using other methods. And basically what I tried to highlight was that while we think we know a lot about the association with reflux and the lungs in CF, we actually, there's a lot of unanswered, probably more unanswered questions than answered questions. And so through that webinar that I gave, this allowed the leaders of the Digest program to bring this issue back to the CF Foundation. They agreed that this was certainly an area that needed to be further investigated, and that identified Chris and Isabel and those of us who have spent a lot of time thinking about this and have an interest in this to put together a workshop series. So it really came out of the Digest program, which is a CFF initiative.
Apologies, I could not unmute myself. Thank you, Jeff. All right, this is for the 3 of our panelists. What were some of our key takeaways from the workshop meetings?
What I would say is, for something that is as important as figuring out how best to make sure that lung disease doesn't progress in patients with cystic fibrosis, as well as if lung transplantation is needed, how best to protect those lungs as long as possible in order to ensure not only that they continue functioning, but also the quality of life. How very haphazard, how very scattered our different centers were. And the reason why we actually started also, what we did, Jeff and I and other members of Digest, the 3rd cohort of Digest, we actually are also planning on doing a survey of lung transplant center providers. And we started thinking about that project because we were describing what was done at our institutions. And I'm at MGH, Jeff is at National Jewish. We had people that were affiliated with institutions in Miami, in St. Louis, and we were recognizing that each of our hospitals did something different. And there's surprising that that's the case, because other transplantation fields have gone towards trying to standardize things. But also there's some subset of patients with CF who won't go on to transplantation because either the body mass index is not high enough, there's concerns about frailty. So we should be figuring out ways to minimize the possible gastrointestinal causes of lung transplant function worsening. So I think that was the main takeaway from this workshop series, is that unfortunately, those of us who are better versed in reflux and digest CFF trainees can't decide what the next best ways to, or what the best way should be to reduce the risk of GI-related aspirations impact on the lungs, then we should probably study it. And that's what this workshop series, I think, helped show us.
Thank you, Chris. Next question, what future research is planned in this area?
So I think I mentioned one project already. I think that Jeff has another couple projects that he'll mention that we're involved with. One project that I'm working on is looking at patients with cystic fibrosis who have cystic fibrosis related liver disease to see what their GI symptom burden is. We're not sure what will happen, and maybe symptoms are worse, maybe symptoms are better, we're not sure. The CFF is really putting a lot of effort into trying to better understand the role the GI tract plays in patients with CF. So Jeff, I'm not sure if you wanted to mention strong CF and nice CF.
Yeah, sure. So yeah, there are a number of GI related research projects ongoing, including one entitled Strong CF, which looks at nutrition and different markers of nutrition, how to intervene on nutritional problems earlier. There's also a new study that just got up and running called Nice CF, which is looking at non-invasive ways to detect and screen for colon cancer, as CF patients are thought to be at an increased risk of colon cancer. Getting back to the GRASP related topic and what future sort of research projects are being planned. Right now, the sort of agreement at the end of the workshop series was really to try to keep as much of the group together as possible, and to potentially create spin-off groups of 2 or 3 clinicians and researchers to try to start to hammer down on these individual questions, research questions that were developed during the workshop series. So this is, even though the workshop series itself recently finished, we have ongoing initiatives to try to keep the communication going amongst centers and keep our leverage in creating both small pilot studies as well as larger trials to really start answering these questions.
Thank you, Jeff. Anything else to add? All right. Okay, last panel question. What else is happening in CFGI research more broadly?
Yeah, again, I think the main ongoing, there are a number of ongoing initiatives right now, looking, as Chris mentioned, at everything from transplant and reflux to liver disease to nutrition, colon cancer screening. That's really the nice part of the Digest initiative, is it sort of allows providers from around the country who are interested in this area, both from a clinical standpoint, but also from a research standpoint, to share ideas and develop projects. And a lot of the projects I just mentioned actually have come out of Digest programs, not only our cohort, but previous cohorts of Digest. In addition, there's also been initiatives to try to, there are similar cohorts of endocrinologists who are working on CF disease. There are pulmonology cohorts as well. And as part of our digest group, we are trying to improve and increase the crosstalk between the GI doctors as well as the other specialists like endocrinologists and pulmonologists. So there's a lot of ongoing initiatives going on out there that not only are GI specific, but also cross over multiple different disciplines.
So the research that I mentioned, looking at CF-related diabetes, for example, is with someone who was in the Envision program. So a CFF-sponsored endocrinologist who spent time dedicating herself to understanding better CF-related diabetes. So these are the examples of CF. I like to remind the pulmonologist sometimes, CF was actually first described as a disease impacting the GI tract and malnourishment. So CF really, its home was in the GI tract, but clearly because the lungs were so much more impacted than other organ systems, that'll hopefully change with Trikafta, as well as other modulators. That's why so much CF-related care is centered in pulmonology. But I think that's part of the rationale now that we have more CF patients with CF living longer and longer, why organizations like the CFF are trying to link other adult gastroenterologists into CF-related care, because a lot of us just aren't as familiar, since it's our pediatric colleagues that would see historically the majority of patients with CF.
Chris, could I take that a little further, speaking on behalf of my CF and post-transplant other patients? What efforts are being done to link and to help find CF patients find those GI doctors that can help with these exact issues? It still continues, I'll use the word problem loosely, to be an issue for some to not have GI doctors familiar not only with CF, but these issues that you're speaking of today.
It's hard. We're still a pretty rare breed. I think that the CFF is working hard in expanding the pool. So right now, its digest is in its fourth cohort, its fourth group. So which means at this point, the CFF has funded a significant chunk of change to, I don't have the numbers off the top of my head, but each grant, I think at least a couple $1 million, I think, based on numbers alone, to increase the pool of people that are more educated in CF-related GI diseases. But what the CFF is also doing, it's inviting us to provide visiting professorships to other centers. That way people know that that people are becoming aware of the increased focus we're playing on CF-related GI disease. Jeff and I are going to be participating in a symposium at the North American Cystic Fibrosis Conference, focusing purely on GI tract symptoms. I think we're one of our colleagues, Christine Hutcham, gave a virtual grand rounds to the American College of Gastroenterology based on CF-related GI diseases. So it's getting out there. It's just going to take time, and it takes effort. But I think a lot of us are passionate about it.
Yeah, I just wanted to highlight a couple of things that Chris just said, but one is that we certainly recognize the fact that not every center has availability of a GI doctor, either at the center, and on top of that, even a GI doctor with particular expertise in cystic fibrosis. And part of the workshop, one of the things that we really spent a lot of time on at the end is what are next steps and how to disseminate the knowledge that we put together through this workshop series. How do we disseminate that out to and make it accessible to the patient population and providers who are dealing with these issues. We also made sure that the sort of CF community was an active part of the workshop series. We wanted to hear where their sort of pain points, where they felt as if evaluation, treatment, communication may have been lacking. And we're trying to use those comments in order to help us figure out how to disseminate our knowledge to centers around the country, as well as how to develop and include as many centers as possible in our research.
Excellent. Thank you both. This is very appreciated. All right, I'm going to go to the next period of our webinar and answer some questions that were previously provided by some people that are on today's call. Okay. What is the difference between GI aspiration and BOS? The person specifically is a post-transplant person and has had the anti-reflux procedure, as we are going to call it this evening.
Well, I can give a very brief overview of BOS as I've understood it over the many years. As our post-transplant patients understand, BOS is bronchiolitis obliterans syndrome, which is a form of chronic lung allograft dysfunction. And this is essentially results in scarring of the small airways or terminal bronchioles. It is a diagnosis based on clinical and histopathological findings, such as biopsy, pulmonary function testing, and ruling out other causes, such as concurrent infection. There are many causes leading to BOS, including, for the most part, many immunological pathways, primary graft dysfunction, which can happen right after the transplant. Grafts may be one of the pathways to BOS. As far as we understand, which our participants and our panel and committee members, we are in the process of trying to understand grafts. As I understand it, and we've discussed, it's retrograde non-acid and acid reflux leading to lower airways findings. But the findings may not be fixed compared to in bronchiolitis obliterans syndrome, where there is fixed scarring of the small airways. As I see GRASP, it's hopefully an opportunity to intervene, but it is not a fixed pathological diagnosis. That's my understanding comparing GRASP to BOS.
I'd agree with that. I think that the reason why some of you may be wondering why we're spending so much time using the term GRASP versus saying reflux is that we don't know what happens in this, what role the stomach has in the contents moving all the way up to the lungs. And when one, for example, gastroparesis, which is a delay in stomach emptying, which you have more stuff in your stomach, more stuff can go in your esophagus, more stuff can go down into your lungs, is prevalent in patients with CF that aren't receiving transplants. But people who are transplants can have damage of a nerve called the vagus nerve, where it may result in the stomach emptying not being normal. So that would be an example of a difficulty of the stomach that may go all the way up and go into the lungs. So GRASP, I would say, to echo what Isabel was saying, maybe of a mechanism for for BOS, but one that is can be treated, but we need to figure out who to treat when and who to test in order to figure out who to treat and when. I think that gets at the heart of what the workshop series is about.
Do you have anything to add?
No, the only thing I'll add to that really is I think we were very careful early on. So GRASP, just to sort of back up a second, GRASP is a new term that came out of this workshop series. So we're kind of throwing it around because we've been using it over the past several months. But if you go, if any patients or other physicians go and start talking to their colleagues about GRASP, I can almost guarantee you that no one else has really heard of this term yet. I've been trying to use it as much as I can with my own patients and colleagues recently, but this is a brand new term that really came out of the workshop series. So early on, we made a clear effort to try to steer the conversation away from reflux, because reflux has a lot of connotations that go along with it, particularly pertaining to the esophagus into the GI tract. And we wanted to make sure that the focus of this workshop series was really on the lungs, in particular advanced lung disease and the transplant situation. And so we tried to come up with terms that were more all-encompassing of GI conditions that may affect the lungs. And so we really tried to get away from sort of talking specifically about reflux and develop this sort of catch-all term of GRASP.
Thank you for clarifying that. I'm going to jump actually to one of what was listed as the last questions, because I think it can piggyback off of what you've just said. And the question was, can you please provide your sources, research articles, and whatnot that we've used for this talk, and I'm assuming also the workshop series. So you just explained a little bit about that, but I think we should go to that question next.
Yeah, my understanding is there's certainly a full set of slides from each of the workshop series that has been shared amongst all the participants, and that we will do our best to make those available to the attendees of this workshop, of this webinar as well, with those slides having references to all the studies we've kind of talked about and discussed.
Thank you. All right, the next question. Is there any overlap in symptomology between this condition and others, such as heart failure? How can one differentiate?
Great question. I would say in general, if someone, I would say not a direct link, but maybe if you develop overload related to heart failure that then impacts the way the GI tract works, then that could be a mechanism where you could link the two. But they're fairly independent diseases, processes, but your stomach is right by your lungs, which is right by your heart. So as much as we think about things as being walled off organs and their systems, there may be something that is there, but not something that we focus on clinically usually.
Anything to add, Jeff or Isabel?
No, I mean, the only thing I would add is that I see, certainly in my clinical practice at National Jewish, we see a number of patients who come in with chronic lung disease and chronic lung symptoms. And I think it's important to push each other, push our colleagues, push our physicians to really think about symptoms, not just potentially coming from one organ system, but how the overlap between different systems, getting at what Chris had mentioned. For instance, here in my clinical practice, the majority of my patients are patients who are sent to me by our pulmonologists. These are patients who came in without any sort of so-called GI specific symptoms. They're not necessarily having heartburn. They're not necessarily having any intestinal issues, but it's really, this is someone who has chronic lung issues that may not be responding to treatment the way we expect. And let's start looking outside of the lungs for other potential contributing factors. So I think a lot of these sort of GRASP symptoms that we talk about, whether it's decrease in lung function, abnormalities on imaging studies, really not just focusing on the lungs, but looking at the heart and the GI tract as potential contributors is important.
Thank you. The next question was a little specific, so I'm going to change it just slightly. If a patient is on Trikafta and they happen to also have a rare mutation, where the GI system is deeply involved in that specific case, is this still going to be something that they should consider? I may be butchering the question, but I think it probably speaks to the Trikafta and the rare mutation.
I'm not sure.
And I think it's a little specific, but anything we want to say in regards to this topic and Trikafta?
We have, yeah, sorry, go ahead, Chris.
No, you go ahead, Isabel.
I will speak basically on my experience as a CF provider, and really there's not a lot that we know. There were, I think, 2 studies that came out recently that overall GI symptoms were improved on Trikafta. However, I would say that there's been a myriad of GI effects, none to some. It's been challenging to characterize any one side effect from Trikafta on the GI symptom, good or bad, in my experience as a CF provider. I'll ask Chris what his thoughts are.
I would say that, so this is where, when I'm not focusing on patients' GI symptoms when they have CF, a large part of my focus at MGH is within the Center for Neurointestinal Health. So I focus a lot on gut-brain, brain-gut communications. And I think that I have some theories which I won't share because I don't have any proof for them. And the fundamental rule of being a physician is you should really only be sharing stuff there's evidence. But I think that Trikafta medications like that are pouring in fluid into the intestines of patients with CF that are used to not seeing a lot of fluid. And any of us who have had, a case of the runs or a stomach bug that has gotten a lot knows that any changes in fluid status in your intestines is pretty uncomfortable. So I think that what we need to see is, if we know that the medications are improving the function of the CFTR protein, the CFTR protein is on the inner lining of the GI tract, which means that likely there will be some change in fluid in the intestinal tract. What that means in terms of symptoms, we don't know. So I think that's why there's some people that may have some symptoms like constipation that may be getting better. There may be people that are now saying, whoa, I used to not have to worry about going this much. Now I have to go a lot more. But it's really hard to, that's the next frontier now that we have so many people and increasing numbers of people on these medications, what the GI tract would look like, what the GI tract would look like in children who are taking these medications versus people who would have had long-standing GI tract disease. We just don't know yet.
Thank you, Chris. Just going to point out we have about 6 minutes left before we wrap up. There's one question that was posed previously. It says, we are seeing dumping syndrome in our CF patients post-transplant, also with our favorite anti-reflux procedure. Is this common at other centers, and what are alternative options?
Chris, do you have any comments from a motility standpoint on that? I don't know if
I
you've
think
seen a lot of, we don't have, I certainly see patients post-transplant, but without a transplant program here at National Jewish, my expertise may not be as much as what you guys have at MGH.
So are we saying dumping syndrome post-transplant or post-fundoplication? Or both?
It's like both. It's like both.
I would say, I am ashamed to admit this publicly, but I encounter dumping syndrome, true dumping syndrome, so rarely that I often have to go back and double check what the diagnostic criteria are to make sure that I hit the laboratory abnormalities or the imaging abnormalities. I'm wondering if maybe it's just more of a change in GI tract function versus true bona fide dumping syndrome. I view dumping syndrome as sort of, you have a rewiring of the intestines related to a gastric bypass, where you may have that be an issue, not necessarily something that would be inherent to a fundoplication or a lung transplant. That's kind of the way that I would answer that question, which is not a satisfactory one, but I would say not dumping syndrome in particular, but GI symptoms after those things, I think yes, which may look like dumping syndrome.
I believe that covers all of the questions that were previously posted. There is one additional question in our question and answer. And again, I'll stress, if anyone has any questions, please do post them there. This person is using Trikafta. It's called different in Argentina, excuse me, since December of 2021. They're still taking enzymes with meals. They're an older CF patient, and Delta 508 is their gene type, and they're just curious, I'm guessing, about some of what we've been talking about respective to that. That is a very specific question, so I'm not sure if any of the docs are able to answer that.
I would say if the question is regarding the need for taking enzymes, y Sandra, también puedo hacer esa pregunta en español si prefiere. I would say that when it comes to using this medication, when it comes to modulators, the pancreatic disease that happens related to cystic fibrosis is because the ducts get blocked up, they get gummed up with mucus. When one is beyond childhood, it likely means that some of that scarring is permanent, which means that likely even with taking the modulator therapy, there will still be a need to take enzymes because the pancreas still hasn't woken up. We hear about, Isabel, sometimes younger patients, if let's say they were kind of like they were not really insufficient, but maybe disease-wise, they would have gotten there in 10 years, where they kind of get or maybe they have some degree of insufficiency where they do take enzymes, but they're able to come off of it because the pancreas kind of wakes up, because I don't know how much of that actually you would see routinely. I tend to see people who are on enzymes, even after starting the enzyme therapies, they still remain on enzymes, but there may be some rare people who are younger where they may be able to become independent off of enzymes.
I'm just going to be cautious of time and indicate we do have one other question. Isabel, I don't know if you want to comment further on that question or move on.
I would just second Chris's thoughts, and especially in a patient who is delta F5 homozygote pancreatic insufficient, that our patients do continue on their essentially same dose of enzymes, but we have seen some maybe partial patients with partial function mutations may reduce some of their enzymes, but that's up for discussion with their provider and here with our GI team and our dietitian.
Thank you very much. One additional quick question, if you feel you guys can do this in a short period of time. But the question was, how many hours before bed should you refrain from eating to prevent aspiration?
The current recommendation, and if you look at most of the GI papers, generally recommends 3 hours before going to bed. So it's a pretty straightforward answer as far as what the recommendations are. Now, again, a lot of that has to do with studies that have looked at reflux testing, which may be different than GRASP, than actual aspiration. So we kind of have hijacked that recommendation from the reflux literature to also comment on what things can be done to try to reduce aspiration risk, but 3 hours is the recommendation.
Thank you, Jeff. Lastly, I will open it up to the three of you. What are you most excited about moving forward after our workshop series, and where we stand with our new term GRASP and moving forward? What excites you? And as a patient, I will say thank you. I cannot say enough how much the work you all have done has impacted me personally, and I am very hopeful for post-transplant and later lung patients, that I think this is just going to be very helpful. But what are you all excited about?
Answering questions that honestly will not only benefit patients with CF, but patients with other lung disease. And I think that we can use CF as the way to guide the rest of lung disease management, especially when it relates to advanced lung disease.
Yeah, I think, this is the topic that I spend most of my week talking to patients about and thinking about. And what I've been most excited about is kind of connecting and finding other providers and researchers across the country who are equally as sort of interested and passionate about this. I'm also very excited at the importance of this issue that the CFF has recognized and allowed us to actually have these workshops and move forward, and wanting to move forward with this. So every time we had one of these workshops, I kind of left fired up, ready to really develop research projects, questions, and get out there and get the word out about this. So very excited.
Isabel?
I second Chris, and and Jeff's input, and am grateful for the support of the CF Foundation as well. My personal feeling, having worked in CF and lung transplant now for 30 years, is that we've known about this and we're finally starting to figure it out, hopefully for our patients after a lot of fits and starts. So I'm very grateful to be involved in this initiative.
I want to say thank you to CFF and thank you to all of our speakers this evening. This recording will be posted to YouTube, and I hope everyone has a great evening. Thank you so much.